Welcome to Insights. I'm Dick Goldberg, and our subject today, eating disorders. What are they? How common are they? Who's likely to suffer from them? What are the trends in this field, and what are the treatments? With us today is Dr. Anna Flach. She's a psychologist. Her career started in Germany as a special education teacher. She then came to the U.S., continued that career, and went back to school to get a Ph.D. and became a clinical psychologist. Her dissertation was on eating disorders, and it was published in the American Journal of Psychiatry. Since then, she's been treating people with eating disorders and has, as we just mathematically figured out, has seen about 3,000 patients. Thanks for being with us.
Nice to be here.
Anna, how common, how widespread in America are eating disorders?
Well, it's a very common disorder. There are about 26 million people who suffer from eating disorders.
26 million?
Yes.
That's almost 10%. That's almost 1 out of 10 Americans.
Yes, that includes all types of eating disorders. It's
Okay.
not just anorexia. Mhm.
Well, that's the next question. What are the different types of eating disorders?
Okay. There's anorexia nervosa.
Okay. Why don't you list them for us, and then we'll go back and
Okay.
try to understand them.
Good. And bulimia nervosa, eating disorder not otherwise specified.
Okay.
And they just recently included binge eating disorder in the
Okay.
category.
Well, let's get to work.
Okay.
I mean, what I'm hoping is in a half an hour we'll have some understanding of this whole area of eating disorders. We won't know everything, but at least have some working knowledge.
Okay.
So anorexia is, why don't you just give us a working definition?
Okay. Anorexia nervosa means starvation, restricting food intake in order to lose weight.
Okay.
Also, over-exercising can be used. And as the patient continues to lose more weight, sometimes they get reinforced by other people, and also their body image changes and gets very distorted. So when they're already emaciated, they still see that too much fat on their body. It's really a cognitive dysfunction at that point when they become so emaciated.
Well, you know, the way you started, I was going to say, well, how are they different? Because so many people exercise and diet and try to lose weight.
But they don't get down to a BMI of 16, body mass index of 16.
What does that mean? I mean, can you give an example of someone who's 5'5"? How much would they weigh if their BMI was 16?
Oh, gosh.
Or at your height, what would you have to weigh to be a 16?
5'3", I would probably have to weigh 90 pounds.
Oh, my goodness.
90 to 100 pounds. But I'm just
Yes.
talking off the top of my head.
Right.
Yes.
Right.
Mhm.
Okay. Well, yeah, I'm 5'5", and I just looked that up before this program, and I would have to weigh about 110
Okay.
to be
Yeah.
in that, or even less.
But there are other things that go along with it. As I said, the body image distortion, the constant thinking about food, food avoidance, fear foods, very strange diet behaviors. Forbidden food. The list of forbidden foods becomes longer and longer, and the list of allowed foods is shorter and shorter. It's a very different mindset as opposed to someone who is maybe a marathon runner and has a low body weight. They can eat whatever they want to.
Now, is this the most common eating disorder or a rare one?
No, I would say it's a common eating disorder that I'm treating.
Yes.
But bulimia nervosa is more common than anorexia nervosa.
Why don't we stick with this in terms of iteology? Why? Why do people get into this syndrome?
When we're talking about anorexia nervosa, it's a solution to an unsolvable problem.
Which is?
It can be anything. That's what we call the underlying issues. But what's very common is leaving home, and my patients will tell me they were so excited to go to college, but the summer before they started dieting. And then going to college can be a drastic experience.
Sure.
You know, making new friends. It's the first time you're away from mom and dad, And although the kids relish their independence, they also have to deal with very difficult issues. That can be one thing.
Okay.
Another thing, very common, is an underlying other disorder like major depression or OCD, obsessive compulsive disorder, or an anxiety disorder.
Okay. Well, how is it that this behavior, quote unquote, treats for them or addresses these issues?
Yeah, when you become so emaciated, you really don't feel much anymore. It's sort of like anesthesia. So in that sense, it's kind of a drug. And kids are, they become sort of, they might have had a bubbly personality before, but their personality changes. They become more socially withdrawn, and their life centers around food and not eating.
Okay. But that's where they get to. They get to this emaciated state.
Yeah.
But what triggers the beginning? Why do they start this behavior? How does that slippery slope start developing? Why?
Well, it starts with dieting.
Okay.
And I guess 40 to 70% of all adolescents are dieting.
Wow.
In our society.
Male and female?
Mostly female,
That's
but
what I'd
there
expect.
are males as well. Yeah.
Yeah.
Actually, it's 60 to 70%.
That's higher. That's lower than I would have expected. I would expect males to be no more than 10% of the. But that might be changing.
With males, the gateway is usually overexercising.
Ah.
And then it goes into dietary habits and dietary changes.
Okay, so let me understand this. So let's talk about this young woman who's 18, a freshman in college or sophomore. And so she's suffering from, let's say, depression. She looks at herself and thinks, I need to be thinner. Right? Isn't that usually how it starts?
Yes. Yeah.
And that will make me feel better? Is that what she's thinking? I'll feel better about myself?
Yeah.
Okay.
Yeah.
And so she starts dieting and exercising, which is, if you're 20 pounds overweight, it's not a dumb thing to do, right?
Or if you're not overweight at all.
Well, dieting might not be necessary if you exercise is good too.
But if you're not overweight at all, my patients can still start dieting.
Ah, why would they do that?
They oftentimes tell me at the beginning, I didn't feel good the way I looked. And those are young women who, in most cases, are just gorgeous.
Wow.
And what that translates into, and I try to help them understand, is they didn't feel good about themselves. But they think, they don't really know what the issues are. But they think if they concentrate on dieting and exercise, or just on dieting, that will solve the problem, and it'll give them some control.
Okay. So they start dieting, and I take it there's no thin enough?
No. As the weight drops, the body image changes, and there's nothing thin enough. If you can squeeze anything in your body, it has to go.
Okay. So if you look at a really skinny woman,
Emaciated.
her ribs are showing, and you say, look at yourself. You know, your ribs are showing. How can you possibly think you need to lose weight? What do they say?
What's the fuss all about?
Oh. Do they deny they're skinny?
Yes. Yeah.
There's your ribs right there showing. How can you say you're not skinny?
They can't perceive it. At that point in the illness, denial is a major, major factor.
Well, why do they want to keep losing weight?
Because it makes them feel good.
Ah, tell us how.
They don't have to. They feel the sense of control. They don't have to experience their emotions, which might be negative emotions.
How does that happen? Why does that block your emotions, being skinny?
I can't tell you from a neurological point of view.
Okay.
But when you're starved, all your senses are into trying to get food. And all of their restraints are not to get food. Now, there is a point in the illness, which is very late, when they're in ketosis, when the patient does not experience hunger anymore.
this is a dangerous situation.
Yes, yeah.
How many people die from this?
A significant amount of people die from anorexia nervosa. It is higher than most of any other psychiatric illnesses, more than major depression,
Yeah.
more than schizophrenia, and the dangerous things are electrolyte imbalance, which we worry most about with bulimic patients, with potassium depletion and dehydration.
Define bulimic patients.
Bulimic patients are those that may resemble anorexic patients, but they still have an okay body weight. They may have started out much higher and have lost some weight, but they are getting caught up in a cycle of binging and purging,
Yes.
or binging and laxative abuse, or binging and exercise, without ever reaching that level of starvation.
But what is the physical danger to them compared to the anorexic?
The physical danger is the electrolyte imbalance, especially the potassium. When you purge, vomit repeatedly, you get dehydrated. Or if you use laxatives, which is more dangerous, you could become dehydrated.
And then what happens? What could go wrong?
Cardiac arrest.
Oh, really?
Yeah.
Is that the same for an anorexic, or is there a different fear?
It can, 50% of our anorexic patients are also bingers and purgers.
Oh, okay.
So they suffer from binging and purging as well at a certain point in their illness. So
the potassium issue, the electrolytes, can be the same. What if you have an anorexic who's not binging and purging? Just
I always feel a little safer, but they could still have cardiac arrest.
okay.
The treatment team really has to include a good physician who monitors all these kind of issues, or extremely low blood pressure.
Wow. And that results in what? What happens then if you have real low blood pressure?
Well, now you put me on the spot.
Yes.
Well,
no, it's not good.
Well, your body can't keep up. It is something very wrong. I mean, if you have a blood pressure rating of 30, that's...
Oh, that's horrible.
Yeah.
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 We know that's not good. So why don't we move to bulimia and purging? Can you give us a little walkthrough on that territory?
Okay. Bulimic patients, as I said, the only difference is that they're still of average weight. They might even be overweight. The other difference is that bulimic patients mostly still experience their menstrual cycle. Whereas, and I forgot to mention that with anorexic patients, they no longer menstruate. They kind of propel themselves into a prepubertal area.
Oh, how does that feel to them?
Well, it's, I guess they don't complain about it.
I mean, is there some psychological benefit or some numbing or something that might happen by
Some
getting into that?
numbing and some fear of growing up.
Oh.
And you still have everybody fussing around you, and you can, and yet you still have that control, because nobody can really make you eat or talk.
Okay. So if we go back again, leave bulimia for just a second. It seems like a cycle that's kind of reinforcing. You get thinner and thinner, and more people are going to fuss over you. You're going to die or be in terrible shape if you don't eat. Isn't that kind of self-reinforcing? Like, oh, good, the skinnier I am, the more attention I get.
There may be some sense of security in having parents set limits, but at the time they don't experience that as a good thing. When they're still in denial, they really refuse to get treatment. And it takes, the parents or sometimes the roommates who bring the patient in, or one of the good doctors at the university who can just take one look at a patient and say, you need to see somebody.
Or this could be anywhere, yeah.
Yeah.
You mentioned control. How much of anorexia and how much of bulimia have to do with wanting to have some control over your life?
Well, we all want to have some control over our lives. And with anorexia patients, there's so much going on, developmental milestones, and so much anxiety that they may not be able to identify, that they feel out of control, but the sort of restricting gives them a sense of control, and also sometimes a feeling of, I can live without the necessities of life.
And what does that tell them?
That I don't have to fear anything.
Oh, so it gives them a sense of self-efficacy of...
Yeah.
Yeah.
I can do what other people can't do.
Uh-huh.
And so I don't have to fear life because I don't even need food.
Wow.
Now, this comes out later on in treatment. They can't express that in the beginning, when they're so emaciated.
Now, if you look at bulimia, binging and purging, is it always binging and purging, or
No, sometimes it's just binging and some other form of undoing.
like
Over-exercising,
laxatives?
a laxative, or restricting. So it's not just the amount of binging, it's the undoing. No, the amount of binging is crucial, but there's always some undoing.
Yes, be that purging or those other options. And how is the etiology of this, if at all, different from the etiology of anorexia?
Well, since the goal is always the same, but my bulimic patients really want more help because it's just kind of a nightmare come true. And there's a total loss of control when they're engaging in binging. And it is really quite a suffering kind of time for them. And they are more amenable to treatment.
And this might sound flip, and I don't mean it to be, but I love cookies. And sometimes I take the whole box and put it in front of me, and instead of eating 2, I ate 5. But I'm not feeling like I'm suffering. Afterwards, I go, I shouldn't have eaten that many. So why are bingers suffering? I would think they'd be enjoying their binge.
Well, initially, eating some food, especially after restricting, feels good because all of our bodies crave food. But then it becomes a rapid overeating and a total feeling of control. And eating
Control
anything,
or loss of control?
Loss of control. And, thank you, and eating anything inside.
Ah.
And it's almost like you go into a trance and you fall asleep.
Wow.
And you can't do it anymore.
What is the need that's meeting? Why are they doing that?
Our body, it usually comes from restricting. And our bodies are made just like our old ancestors. And, with our old ancestors, they didn't have food for a while. And so they would have to gorge themselves when they finally did get food.
Yeah.
And our bodies are still wired that way.
Yeah. So, in terms of other, want to cover the whole gamut here.
Yeah.
So we've got anorexia, we've got bulimia. Any other fairly frequent eating disorders besides those two?
Eating disorder, NOS, not otherwise specified.
Which includes?
Which includes, let's say, typical anorexic behavior, but the person hasn't lost their menstrual cycle yet.
Okay.
Or typical anorexic behavior with lots of fear foods, but the patient started out at a very high level, like 190 pounds for a male, and is now down to 145, but can't feed himself in a properly way. But the body mass index is still 22.
Is it heading down to a dangerous level, the body mass index, or is it plateauing, you're saying?
Well, he's in treatment now, so we're trying to get him up, not to 190 pounds, but to eliminate the fear foods.
What do you mean by fear foods?
The foods that induce a lot of fear in my patients and usually don't get touched, like pizza is a typical example, or anything that tastes good.
Okay. Okay, so any other disorders that we haven't covered? What about night eating, or
What about what?
night eating? People who get up at 3 in the morning and eat, or any other subsets of this NOS?
That might cover the binge eating disorder.
A subset of binge
Yeah.
eating. Okay. I hope to have you back, and we'll talk more about the generic overeating, but not an eating disorder, and emotions and eating. But let's continue on this subject in terms of the demographics. Now, you've said that 70% female for anorexia, true for bulimia as well?
It might be higher.
More women. Okay.
Yeah, more women.
The media sure doesn't portray men with these eating disorders. It's very
Men
surprising.
have been underdiagnosed.
Really? How come?
Yeah. Because it is so associated with females. And it doesn't come necessarily from a body image distortion.
Ah. And what does it come from? How is it different with men?
The very similar conflicts than women, going off to college, not knowing how to make friends, being unhappy, and not feeling like you fit in, and then you start exercising and losing weight and developing fear foods and things like that.
What I'm hearing is there's some looking for symptomatic relief, maybe by eating too much or binging, but ultimately this becomes what is a phony solution to a problem.
Yes.
I don't know, for lack of a better word.
Yeah, but it works in the short term.
Yeah, giving you a sense of efficacy and control.
Exactly.
And like,
yeah.
I'm getting thinner and I'm really,
Right.
yeah.
And I want to tell you a story. And I've treated several males, and they've all done well. But with one male whom I saw 2 years ago, they could not. He lost weight, and they could not make a diagnosis. It took literally, his mother told me, $25,000 before the Mayo Clinic came up with a diagnosis of anorexia
Now,
nervosa.
if you had seen him right off the bat, you think you would have seen it?
One of my patients would have seen it.
Wow.
One of my patients would have seen it in 5 minutes. They're so
Wow.
sensitized
Wow.
to when people have fear of food.
Well, how come they all missed it? How come all these professionals
Because
missed
he's
a guy.
he's a male. Yeah.
Wow.
And lost and you know, other things need to be ruled out when someone
Sure,
loses that
of
much
course.
weight. Yeah. So
How often do people come to you on their own saying, I need help, versus they're sent by proxy by mom or doctor or whatever?
seldomly.
Seldom come on their own.
Yeah, bulimic patients sometimes come on their own.
But anorexics?
No, because many of my patients have a very low BMI when they
Body mass index, okay.
body mass index
Yep.
when they really could be in day treatment or should be in day treatment or a hospital, and they sort of give them one more try with me, and if they don't make it, they go to day treatment.
So there's a threat there. You're going to be locked into hospital if you don't get day
or
treatment.
day treatment.
Yes. So that's how you get them in, with a threat.
Yeah. Well, I don't.
Not you, but,
I don't-
but mom or whoever.
or the doctors.
Or the doctor says
Yeah.
we're going to have to put you behind a locked ward if you don't, to save your life, right?
Yes.
Is that, I'm a little ahead of you, but is that often the case? It's to
That
save
is
that-
often the case. Yeah.
It's life-threatening. Yeah. Okay, well, let's talk about protocol. How do you help people? First of all, if you compare anorexia to bulimia, which is more likely to have a successful outcome when you treat them?
You know, bulimia is not. It depends on the intensity of it. It is not such a. It is a serious disorder, but most people would assume that anorexia nervosa are patients who are harder to treat because they're in such denial.
Yes.
Now, for me personally, it is easier to treat anorexia nervosa patients.
Really?
Yeah.
Why?
Because when you form a good relationship with them, when they kind of tell you how they're suffering, and when we make a pact in terms of weight restoration, because by now I have to do the weight restoration as well as the underlying issues because they're not in the hospital, the university is a great backup for me, and the dietitians are important. With a good relationship and a lot of support, usually if the patient is not chronic and if it's been discovered early enough, I can help them restore some of the weight.
How the heck do you do that? Because I think they're coming in by proxy. They don't want to be there. They're denying the problem. How do you enlist them to do things like have a goal for a higher weight when they think it's not necessary?
Well, there are two things the patients want to avoid. They want to avoid being pulled out of the university, and they want to avoid going to the hospital. And that's what you have to work with in the beginning.
Okay. So they're motivated for fear of something worse happening.
Yeah.
Okay.
But that's only in the beginning.
Then what?
And then when they have some success and the relationship forms, the therapeutic relationship forms, they become, they get more out and out of their denial.
Oh, how does that happen, and why does that happen?
Well, because I think cognitively they think a little bit better.
Is that because they're gaining some weight or getting more nourishment,
Yes,
or because of your relationship?
They're getting more nourishment. They think differently. Yes, and the therapeutic relationship is of utmost importance.
And as a therapist, what are you thinking? What are you trying to change in their head or heart?
Well, what I try to change at first is, and if I can get the parents in, that's wonderful, for a first visit or second visit or third visit, that this disorder has very little to do with weight and food. But right now, weight and food and weight restoration is everything. That's how we know whether this is going to work or not. Later on, you will find out that it has to do a lot with emotions and other things, and growing up, then with weight and food. But right now, weight and food is it.
By the way, what age group suffers from anorexia? I assume that you're talking 16 to...
Yeah, 16 to college age. There are exceptions.
16 to 22.
Yeah, 24. Okay. There are older women too, or there's some chronic patients.
But pretty much it's in that age group. And how about educated versus uneducated?
Well, Hilda Brooke, who was one of the pioneers in eating disorders, used to call our patients the golden girls, those that had everything going for them, and yet suffered so much and denied themselves so much. But it's become clear that it has filtered down to, I don't want to say down, it has filtered down to socioeconomic status and also a more diverse ethnic population.
Not really good news, is it?
No.
Okay, well, let us move on a little to treating bulimia. I know we didn't do an in-depth job, but I get some feel for it. Before we leave it, how long is the course of treatment for anorexia on average?
A year and a half.
Wow.
Easily.
Wow. Bulimia, how long is the course of treatment?
And I'm talking about people who've been pretty sick and should have been hospitalized.
Okay. And how about for bulimia? What's the typical length of treatment?
That can be anywhere from 6 months to a year and a half.
And is it the same issue? Like there's an underlying emotional issue that has to be addressed if this is...
Yes, it's a solution to a problem.
But how is it different treating a bulimic than an anorexic?
Well, with someone who's bulimic, you have to tell them what food is really doing. I always say if you make food your enemy, you're going to lose. They really try to restrict, but then the way our bodies are built, we eventually have breakthrough eating. And you normalize it to the patients. That's how we are made.
You're going to want to binge if you restrict.
Yeah. That's what it would happen to just about anybody.
Let me guess. The cure here is getting them to eat regularly rather than restricting so much.
Right.
Good guess, huh?
Yeah, that's a very good guess.
Huh.
And I always say cherish food.
Oh.
Because food becomes such an enemy, and food is so associated with guilt that anything they put into their mouth they feel guilty about, as opposed to someone who is a normal eater. they can cherish food. They wait until they have regular meals. They wait until they're a little hungry.
But it's not the enemy.
No, it's good. It feels good in your body, to have food in your body. And so I try to normalize what food really is, because they have lost touch of that.
You've been in this field 30 years.
Yeah.
Has there been any dramatic changes in treatment?
Well, nowadays, 30 years ago, we had inpatient and outpatient.
Mm-hmm.
Now they're day treatment programs and residential programs for chronic anorexics.
Mm-hmm. Okay.
And they all have their place. And I have changed my way of working. I had to. Because when I saw patients 30 years ago, we had an eating disorders unit at the hospital here.
Mm-hmm.
And so I would see them for treatment. But
in the hospital when they were in...
They would either come to my office or I would
okay.
see them in the hospital.
Yeah.
So weight restoration was left up to the hospital, and which is a pretty easy thing to do in a confined
Yes.
environment, But we don't have a hospital unit anymore, and I don't know if it's even that necessary. I think you can do weight restoration in most cases when it's not chronic on an outpatient setting. But you can't see the patient once a week. You've got to see them 3 times a week.
Okay.
And they send me their food protocol every day per email.
Well, email's new. That's a change.
That's
No,
Mm-hmm.
long ago, but still a change. Any a couple of clarifying points before we close. One, are there any myths about eating disorders that you would like to dispel?
Yes. One myth is that it has only to do with body image or some kind of vanity thing. It doesn't. There are always emotional underlying things.
Okay. And finally, to people who are concerned about loved ones who they think are suffering with one of these eating disorders, what might they do? What might they change in their behavior?
Okay. With parents, they need to really, although the kids are over 18, but the kids tell them, I can't feed myself. So they need to take action, and they really need to get treatment.
How do they do that? What if the kid says no? Not kid, but the young person says no, I don't want it.
Well, parents still have a lot of clout, don't they?
If you have a 19-year-old daughter, what can you do?
Well, if you're that starved and emaciated, you're not going to go to college.
Okay.
Or you go to the hospital.
But don't passively sit by.
No. You really have to take the reins in your own hand. And then I like to work with the parents. I only get to see them once or twice because many of my patients are from out of town, but it's always very helpful.
Mm-hmm.
And if they can follow treatment recommendations, despite the kids whining about it, if they can.
When you say if they can, you mean if the patient can, or if the parents are
if the
involved?
Parents.
That you give treatment recommendations to parents?
No, I give treatment recommendations to the patient.
Yeah.
But I want the parents to hear what the treatment recommendations are.
So they're on board.
So that they are on board. And if I can get them on board.
Sometimes you can't?
Sometimes I can't.
Why?
Because sometimes parents are in denial as well.
What would be a treatment recommendation parents wouldn't buy into? Can you give me an example? I thought we were done, but I got to close with this.
When sometimes parents have the erroneous assumption that, what can we do right now? The kid doesn't want to get better.
So, yeah.
And I always
so they're in
say,
denial.
they never want to get better.
Uh-huh.
We've got to handle it now. The sooner, the better.
Okay, well, I hope one person hears this who might not have done anything. And
Yeah.
Anna Flach, I thank you very much for all this information. It's really helpful and illuminating.
Thanks.
And I hope you'll join us on the next edition of Insights.